Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Johnson & Johnson.
Welcome to our presentation on Orexin and hyperarousal in MDD. This is a rapid-fire review. I'm Dr. Leslie Citrom, clinical professor of psychiatry and behavioral sciences at New York Medical College in Valhalla, New York. And I'm joined with Dr. Joseph Goldberg. Joe?
Les, thanks for having me. Thanks, everyone, for joining us today.
Yeah, so Joe's a clinical professor of psychiatry at the Icahn School of Medicine at Mount Sinai in New York, New York. Let me start this off by asking you, Joe, how is this emerging orexin-based antidepressant strategy different from the dual orexin receptor antagonists, or DORAs, already approved for insomnia? And what are we talking about here?
Yeah, so we've known about the orexin system since the late 1990s. Implicated in wakefulness, as you say, Les. We often think of narcolepsy as an instance where there's a relative deficiency of orexin neurotransmission, and that leads to sleep attacks. And if you could have an orexin receptor antagonist, it's another way of getting at the sleep cycle, not by imposing a soporific effect so much as taking the battery out or downgrading the wakefulness pathway that the orexin receptors are involved in. So the dual orexin receptor antagonists, drugs like suvorexant, lemborexant, daridorexant, go at both types of orexin receptors. One is known as orexin 1, the other is known as orexin 2. Turns out they do different things. The orexin 1 receptors, which are very expressed in the locus coeruleus, seem to play an important role in emotional processing and arousal. And to a somewhat lesser extent, wakefulness, whereas the orexin 2 receptors are all about wakefulness. These are receptor targets that seem to play a very important role in the ascending arousal pathway in the brain, and a dual orexin receptor antagonist may not necessarily allow for the expressivity we're aiming for from orexin 1 if we're hitting both. So it's sort of an interesting paradox. Orexin 2 seems to be particularly relevant for the sleep effects of orexin antagonists, whereas orexin 1, if we were to single out a single orexin receptor antagonist, may not do as much in only the sleep sphere, so much as to encompass the arousal and emotional aspects of processing that encompasses sleep as part of depression. So when you think about this, sort of interesting question, dual orexin versus single orexin, we're just really at the beginning stages of having data on these things. If we look at what's known about the dual orexin receptor antagonists, there are some data at the moment looking at MDD. I know there's one drug known as Hyperarousal that had just some preliminary data. That's a DORA. What do we know about DORAs in MDD?
Well, when the DORAs were first introduced, it offered us a different way of addressing insomnia, right? Instead of pressing on the sleep switch, we dial down the wake signal. It turns out people with major depressive disorder, many of them have problems falling asleep and staying asleep. And this is, typically that middle-aged person with MDD who's not sleeping and not eating. And I want them to sleep better. And, reaching for a DORA makes a lot of sense there. It also regulates REM sleep. Problem is, it hasn't been really investigated to the extent that is satisfactory. When we take a look at one of them that's not even available, Phylorexin, it's a DORA that's not currently marketed. It was actually tested in patients with MDD, and particularly in MDD partial responders. And they looked at the Montgomery-Åsberg Depression Rating Scale total score. Unfortunately, it was no significant difference with the control condition, placebo, at weeks 3 and 6. So that's a problem. And what is there left for us to think about? Well, is this a lost cause? Well, they did look at some patients with MDD with lemborexant. Unfortunately, what was examined here were sleep outcomes and not depressive outcomes. But nevertheless, you can give lemborexant in patients with insomnia receiving medications for depression and anxiety, that's for sure, and they'll sleep better, that's for sure. But will it get at depressive symptoms? We just don't know. There was a look at suvorexant and comparing it with azopiclone. Tough name to pronounce. It happens to be that one Z drug that actually tastes pretty bad. And both are used to treat insomnia, and both are used to treat insomnia and MDD. What was examined here were, again, sleep outcomes. And uh, both worked. I mean, there's no statistical differences between suvorexant and azopiclone, but we don't know about MDD outcomes. So this is something that we must find out more about in order to think about the strategy. So far, we've had an accumulation of data on a SORA, single orexin receptor antagonist. So what does the SORA adjunctive MDD strategy tell us in terms of the clinical data that was produced?
So the SORA that has thus far been studied as an adjunct in MDD is seltorexant. There's some phase 2b data with this molecule. There's a few studies thus far. First was looking at seltorexant at one of different doses, 10, 20, or 40 milligrams a day as compared to placebo, with the main outcome here being change in depression symptoms using a standardized rating scale known as the MADRS, or Montgomery-Åsberg Depression Scale. So in that first study, there was actually no significant dose-response relationship. With a further analysis, there was a significant change that was evident at weeks 3 and week 6. On a secondary outcome, looking at another rating of symptoms, there was a numerically greater improvement with a 20 milligram dose in patients who had a significant degree of insomnia starting out. And it was well tolerated. So no discontinuation rates different than placebo on outcomes such as somnolence or nausea or other sleep problems. And the second study looked at seltorexant added to antidepressants in a larger group, about 300 patients or so per group, looking at 20 milligrams a day. And here there was a statistically significant difference, again on the MADRS scale for major depression, and on secondary outcomes, significant improvement at 20 milligrams versus placebo on all secondary outcomes, and again with very good tolerability. And a third study took seltorexant as compared to quetiapine ER. That's a drug that some clinicians sometimes think of as, well, it does have its indication as an adjunctive therapy in major depressive disorder, not by itself, and it can have some hypnotic effects. So some people think about that as an option. So here was a comparison of seltorexant as compared to quetiapine. The main outcome that was looked at here was response. That gets defined as, are you at least 50% better than when you started out in depression symptoms? Turned out there was a numerical advantage for seltorexant over quetiapine at week 26, but it wasn't a statistically significant difference. So there was less study discontinuation with seltorexant as compared to quetiapine. That was a more likely drug for people to say, it's going to be hard for me to stay on this. So a bit indeterminate, a positive signal. It's certainly encouraging, but we're waiting for more data to get more definitive findings on this and potentially other SORAs. But as we think about where the field is at the moment in the SORA meets depression world, Les, any particular types of major depressive disorder patients you might think of as being particularly appropriate candidates for this sort of approach?
Well, actually, it's quite common. In my private practice, I would encounter patients, let's say in their 40s or 50s, with their very first episode of major depressive disorder. Invariably, they would have decreased sleep and decreased appetite, disturbed concentration, and they were hyper aroused in some ways. They just couldn't settle down and go to sleep. And that's where I would think an antidepressant like an SSRI or an SNRI combined with seltorexant may be quite helpful. I wouldn't give it to someone who is, for example, sleeping too much or is easily sedated, but those who are kind of more active than they should be and not in a good way. I would also want to make sure that they don't have a underlying insomnia disorder as well. And this is something new that they're presenting with. I think that would be an ideal candidate. And there are many of them where I find the SSRI or SNRI not good enough. And this is a way of perhaps augmenting that SSRI or SNRI without resorting to a dopamine receptor blocking agent, for example. So, how do I explain, though, that this is really an antidepressant and not just a sleeping pill? Because sometimes they think, well, you're just giving me, a sleeping pill. Why don't I just take, Zolpidem, which I took in the past? So, what's the difference there?
Yeah, excellent point. Well, so if you indeed have two separate disorders, primary insomnia, you may be a candidate for an independent sleep intervention. But as you said before, Les, if I construe your insomnia as a symptom of your depression, then I want to try to encapsulate that within the model of treating the depression. So if I'm using, let's say, benzodiazepines or the Z drugs, um, I'm not going to make much headway into your depression. That's not been shown. And I am going to pay the price in terms of adverse cognitive effects the next day with at least some of those compounds, the potential carryover effect in terms of sedation, lethargy, fine motor coordination. So those agents targeting sleep, which are meant to be short term, may be helpful, but we've almost sort of been stuck with them all these years. We haven't really had a very good and well tolerated approach to treating depression with a kind of an in-house way of targeting the insomnia symptoms. So this may end up being something of a new classification, that is to say, antidepressant molecules that have some intrinsic properties on the sleep-wake cycle without causing some of the baggage that we often think of with things like benzodiazepines or even the Z drugs. Think this approach might change how the multidisciplinary team, the prescriber, pharmacist, therapist, others might manage patients who have depression with insomnia?
Yeah, I think this requires some education across disciplines, and that MDD is related to alterations in REM sleep, possibly, and that what we do to help people sleep that alter REM sleep not in a good way would not be helpful to the patient. But if we can alter it to normalize sleep with regulating the orexin system a bit better than what we see in the disease state, then I think we'll make advances here. And this means interfacing with primary care and pharmacy. We need to know what other medicines a person may be prescribed by other providers. This is easier to do in the age of electronic prescribing. I see on my app right away what the patient is receiving from other people, and we can perhaps avoid bad practices there. But it requires collaboration and communication and presenting a unified message to the patient. They're going to get information on the internet as well. So we need to be mindful about curating information as best we can. We also can consider cognitive behavioral therapy, CBTI, for example, which can be quite helpful and often can be used in conjunction, of course, with medicines to treat MDD. And sometimes patients would go for that in order to somewhat minimize exposure to different medications. But a selling point of a SORA is that I'm not giving a dopamine receptor blocking agent that when they look up is indicated for schizophrenia and bipolar disorder. I'm giving something that is actually very directed towards a sleep problem.
And indeed, it's also reintegrating the notion that the insomnia is a core symptom of the depression. So before we piecemeal add this pill for this symptom, that pill for that symptom, if we can make something more parsimonious, I think it's in the spirit of simplifying a pharmacology regimen and also engaging the patient's educational awareness of what comprises depression. And if this is one symptom of a syndrome, well, they understand that better. And so they don't think of themselves as having lots of different pills for lots of different reasons.
Yeah, I look forward to having another choice. I think choices are good. And if something doesn't work, we can try something else. This is a different approach. Well, I want to thank our audience for participating in this activity. You can find useful tools and resources on the right hand side of this page.